And what we found is that the best performance was in the urban private practice, and then rural areas, and then in tertiary care center, because tertiary care center gets difficult cases, so atypical morphology. But what we found is that these tools, they worked very well in the hands of dermatologists who already know. But when we tried to assess in the primary care physicians, it didn't work so well. So another problem and big challenge is interoperability. So, and a recent study, a very interesting study published last month only, that they gave, this was a randomized trial in which the chat GPT was tested against chat GPT plus a human physician and human physician alone. So chat GPT performed better than human physician and human physicians plus chat GPT. So even if you have a tool and you don't know how to use that tool, it's not going to work. So that's in brief. Yeah.
Thanks a lot for your input, sir. So before we ask the audience about a possible question from their side, I would want to ask you one thing, sir. That one challenge which you probably faced was in, if I may use the term, selling of the technology to the people at large. I'm just using for the sake of convenience. So it was because, let's say, like you said, that primary care physicians were not able to use this technology. Was it because they were not aware of the terminology imperatives, or they were not aware of the technology part of it, sir? So what could have optimized their uptake?
So even we with the help of NGOs, we tried to implement it in certain primary, what you call mohalla clinics in Delhi areas. But I think they were not so, they are not so familiar with the technology, number one. And triaging is a problem because they are already overburdened. And if you want to add another step in a management of patient while a long queue of patient is already waiting for them, then it's not going to work. And there are so many other challenges. It has to be very simple. It has to be smartphone of, deliverable, and there are many variables. So creating a technology is one, but implementing is altogether a different kind of challenge.
So I guess we are looking at a loop wherein, since we are busy, we are not finding time to adopt the technologies, and that's what is keeping us busy all the time. So that's an interesting aspect. Can I have one quick question from the audience? Of course, we'll have more questions at the end. Yes, sir.
I must ask him something. So what I wanted to know was, when we see patients, we see the patient in 3 dimensions, whereas a photograph is in 2 dimensions. And it's at least happened with me several times that when I've seen the patient directly, I've had a different impression than when I've seen the photographs before, because the photographs were in 2 dimensions, of course, in slightly more difficult cases. I'm not talking about the absolutely garden cases. So the 3rd dimension gives me an additional perspective. Now, what I want to know is, now your images are all 2 dimensions, and the resolution of the images, of course, would vary depending on how they have been taken. So would the lack of a 3rd dimension be an impediment to the incorporation of AI in dermatologic diagnosis?
Thank you, Manas. That's a very important question. At the same time, while ideal would be a 3-dimensional image, an AI trained on that 3-dimensional image data set. However, this is not going to happen in near future. But what I found is that in spite of having just 2-dimension image accessible to the AI solution, it comfortably beats in a specific task to dermatologist. And the best example is of skin cancers. And all over the world now, the AI-enabled diagnosis is superior to dermatologist diagnosis as far as detection of skin cancer is concerned. So in that specific task, even with the 3-dimensional access to 3-dimensional examination, the 2-dimensional image in AI conveniently beats it. I give you another example. What AI can read in an image is and analyze is enormously different from what we look at it. atopic dermatitis. So some of the patients with atopic dermatitis have atopic dermatitis because of the filaggrin mutation in a protein gene, protein which is expressed in the skin. So AI, when it was tested, the AI was fed with the skin images. It could accurately diagnose filaggrin mutation in more than 70% of the patients by just looking at the images. And what we are working in collaboration with AFMC is we are trying to find out whether by just looking at the facial images, the AI can detect metabolic syndrome in patients with chronic plaque psoriasis. Because this has been replicated, not exactly this, but a Chinese study suggests that by just training the AI model with the facial images, it can detect the heart condition in a patient. And an Australian study suggests that by just looking at the chest CT scan, it could predict 90% correctly the mortality in the next 5 years of a person. So by just looking at the CT scan of a person, which is also two-dimensional, the AI can predict accurately whether this person would survive for next 5 years or not. No other data.
So, just one little supplement. What about adding dermoscopy? We know that in malignancy, the addition of dermoscopy is actually the thing which has made the difference, rather than the clinical images. So, so would you think that the addition of dermoscopy, a clinical and a dermoscopy, would make things better for AI, especially when we have this issue with primary care physicians?
Yeah, I completely agree with you. As I told you that by having just one kind of information, we had already hit the ceiling, and we couldn't improve the accuracy of the AI model further in spite of adopting the newer technologies. So if we have like multimodal inputs like patients' metadata and other things like dermoscopy images or histopathology images of the same patient available to the AI tool, the accuracy is going to be super high.
Thank you, sir. So what I understand out of this is that one thing, it's easy to create technology probably these days, but difficult to apply. One of the reasons would be because it need to be sold in that sense. By explaining it well, probably it will take some time. And to explain it well, ab initio, we need to understand it well as well. And also, it will be difficult to apply or implement technology in one silo. We may use it in a silo, but it has to apply probably in a more 360 manner. I think we are on the same page on this. So with that, let's move on to Dr. Subhash and let's see what he has to say about integration of AI or AI in his field domain.
So I have a small presentation if I can run that. So it's about how.
Can we have Dr. Subhash's presentation?
And just to answer about the 3D and imaging and all, so it's going to come. It's already in the pipeline. The biggest lab working on AI is the Mahmood Lab in the US, and they've got a lot of funding about 3D imaging, be it histopathology, image, or radiology. So what they do, like in case of pathology, at least when we see it's a section, it's a 2D section, but see it's just 1% or 2% of the entire tissue which gets sampled. So now they are coming up with technologies which will replicate that biopsy in a virtual way, stain it in a virtual way, so that the entire biopsy gets what you call documented as multiple tiles, maybe 256 cross 256 tiles, and the AI model will look each tile separately, and because the images are so heavy, it converts the image to a text. So it will be maybe like a metadata analysis. So it will be in kilobytes, and that data is used for predicting, diagnosing, and prognostication. At least in pathology, the 3D is going to come.
So that tells us also why it is so difficult to sell tech. You know, we have glitches and glitches.
So in pathology and radiology, the AI has penetrated a lot now. So in pathology, there are a lot of revolutions. The recent one was the molecular pathology, and now the next is the AI and computational. This is how the journey of a glass slide happens, and the pathologist sees the glass slide for diagnosis. Now we have an added step. The first step for using any AI model in pathology is to scan it and make a whole slide image. So there's a lot of advantages of going digital, that you can report it from anywhere and use these images for AI models. So there's a lot of opportunities, but there are challenges in terms of storage, transport, cost. Now what happens, like only generating a digital slide doesn't help. You have to use it in a setting which will help the larger masses. So when it comes to AI models help in diagnostic, theranostics, predictive, prognostic, a single glass slide without doing any other additional test. An AI model can help you doing all these things. It has to be a specific question and a good refined data to do it. So many of us have seen reports of, say, neuroendocrine tumor, grade 1, grade 2, grade 3. It's all basis on the MIB1 index and the mitosis. It's a very subjective thing, like a human counting a mitosis or a MIB1 or a Ki67, and a 3% becomes grade 1 and a 4 becomes grade 2. So here we can use an AI model. This is a QPath software. If you use an AI model, it will highlight the positive cells. It will give you a score that these many out of this many were positive, and it's an objective method. And a grade 1 neuroendocrine may go for observation, and a grade 2 may require intervention. So that's how critical a pathologist diagnosis is there. Identifying tumors, the patterns of the tumors, you can use a lot of AI models which can identify your tumors, how they are, the grade of tumors, like a squamous carcinoma. Many of us have been doing head neck. Identifying a pattern 5 is a poor prognostic. An AI model can pick up how far it was. A pattern 5 has to be 1 millimeter away. Protein expression, like I said, breast cancer without an HER2, ERPR and HER2, no medical oncologist is going to touch the patient. Now, if a IHC is taking 7 days, an AI model may require 2 minutes to predict whether the tumor was HER2 positive or HER2 negative, only on the basis of your H&E image using the computational power. An H&E image can predict a lot of things, like whether there's a tumor, or there's how to subtype the tumor, classification. Using a squamous carcinoma data can be used for any other sites which is also squamous, like a cervix cancer, so that the AI model has to be generalized. Lymph nodes metastasis, like I come from a cancer center, the Tarmamel Center, where we are dealing day in, day out with oncology, and major bulk is the lymph nodes in our trays. So missing out in the evening, you're tired, you might miss out a small node. So all these things are there possible, and in our lab, we are working on it. There may be scenarios like 2 patients having a stage 2 age-matched disease, but they behave differently. So it is the AI which can predict the pattern recognition, like this was different from in one case than the other, and it may help for escalation or de-escalation of the therapy. So a lot of things have been going on, the tumor infiltrating lymphocytes, the stroma, everything predicts. So I'll talk about what we are doing in our lab at Mumbai, the TMC Mumbai. So annotations of the AI model, the first requirement is to how to annotate the data. So we all use a Google Capture to log in anything, like be it the bridges, the water pumps and what all. We have developed our own pathology-based Google Capture, where for login, a pathologist has to identify the annotations correctly, then only he can log in. So that helps us to give us an annotated data. So without asking a pathologist to do something, they are doing it. This is one of the paper which we did. It's about the ERPR using H&E, and we had published this in JPath Inform. It had a very good accuracy of over 85%, and as we say, an AUC of more than 85% in